Welcome to the award-winning AUA Leadership and Business Podcast, an official podcast of the American Urological Association.
Welcome to the AUA Leadership and Business Podcast, where urologic professionals experience the practical application of business acumen essential for success in today's dynamic professional landscape. I'm Dr. Jennifer Miles Thomas, and in today's episode, we will explore the multidisciplinary group model with Dr. David Albala. Dr. Albala is the Chief of Urology at Crouse Hospital in Syracuse, New York, and Treasurer of the Associated Medical Professionals of New York Physician Clinical Council. He's considered a national and international authority in laparoscopic and robotic urologic surgery and has been an active teacher in this area for over 20 years. Fun fact, he is also a past White House Fellow from 1995 to 96, who acted as a special assistant to Federico Pena, Secretary of Transportation, on classified and unclassified public health-related issues. Welcome.
Well, thanks, Jennifer. It's really a pleasure to be here today, and I'm looking forward to talking about how we've integrated a multidisciplinary approach in our practice and taking care of urological patients. So I think we'll have a nice discussion to talk about how these models can be set up and what the pros and cons of this type of system is.
No, that sounds great. I think a lot of us in practice are always trying to figure out how to do things better. Everyone is busy. Everyone's trying to provide the best possible patient care. Patients are sometimes trying to navigate through the system. So this is so timely and so important of just how can we set things up differently. So can you just kind of start from the beginning? What is a multidisciplinary group model? How do you, what does it mean? How do you structure it?
Sure. Well, essentially, I think that we need to look at what the traditional practices have been. When I first started, we were just a group of urologists taking care of patients. And I think as we've grown over the years, we've learned that teamwork is really essential to providing essential patient care. And we saw this first, I think, in oncology services, where you'd have a urologist talking about prostate cancer, but then the patient would see a urologist, and then a few weeks later go see a radiation oncologist. What we've tried to do in oncology services is form multidisciplinary clinics where all of different physicians have been together and can see the patients all at once. And sort of from that is this outgrowth of now we can integrate this in a much larger model in a full practice. So in our practice, for example, we have urologists, we have radiation oncologists, we have pathologists, we have radiologists, and we've started to now incorporate medical oncologists into our care and our practice. So patients can come in and essentially have, single stop shopping, so to speak. They can get their services done all in one setting, with all the providers under one roof. I think this is really important because it allows for collaboration and synchronization of care, and we're able to provide, integrated, comprehensive, and personalized medicine to our patients. And I think that's so important going forward. As we get in these complicated systems, if we can streamline the services for patients, making it easier. We have lab services available. We also have a pharmacist that can provide, drugs for patients, especially cancer patients, that are so needed, so they can do everything under one roof. And that's really the model that I think, we've been successful at developing. And I think that this is going to be propagated even going forward.
Well, can you talk about how it's structured? So there are many different practice structures that we all have, from private to affiliated to hospital employed to academic. So is everyone under urology, or are there different departments that just collaborate so that everyone can be available at the same time? Can you kind of describe that?
Yeah, at least the governance structure is, based on one group. We have a physicians council that's made up of, urologists, radiation oncologists, different providers, all, provide the leadership for the group. Decisions are made, in a group setting. There's not one group that acts separately per se, but what this does is it allows interaction, better communication, and that's really, I think, the essential thing about a multidisciplinary approach is that the communication, essentially eases the communication lines. So if there's a problem with, radiation services, they can discuss it, in an open setting. We have different opinions that can be, discussed, and then we make a decision as a group. So, no one has more power than another specialty per se. We look to try to provide streamlined services and collaboration to the patients. And that's really the bottom line.
Okay, so it sounds like there's a lot of benefit to us as professional clinicians as well as the patient. Are there any other benefits that we should think about?
Well, I think there are a lot of benefits. I think that, for example, the learning and relationships can be developed. The professional learning, there's the ability to provide, better streamlined services to patients. Getting the patient in the door through all of these different providers, and it doesn't have to be just in oncology. We've been looking at a model of possibly bringing in a urogynecologist in our practice to integrate female services. We have, urologists providing men's health care, and men's services. So trying to integrate all of these services and instead of siloing, creating silos, I think is really important. And really what it does do is it provides sort of streamlined and personalized care for these types of patients. We've noticed that with this model, you can get increased patient satisfaction. We have scores, Press Ganey scores that are sent out to patients, and we take those, satisfaction reviews very seriously and try to change our practice and adapt our practice accordingly. It also allows for increased use of ancillary services. So we can look at what types of, lab work can be done. If we're going to do sophisticated genetic testing and so on and so forth. So all of this is all integrated, all in one, and it really makes, I think, sort of more personalized and comprehensive care.
So that makes sense. I mean, some of us are familiar with like executive health, how things are very structured and organized so the patient's journey is very smooth. For all of us though, our templates are full, patients are waiting. Does it help with just increasing capacity through the clinics? Can you see more patients or see the correct patients at the right time? How does that work?
Well, it does. I think what's unique is, it's allowed us to share between the different, specialties, between radiation oncology and urology and medical oncology. We can look at things that have been successful. For example, I'll give you an example. In my practice, I have a busy clinical practice, but one of my radiation oncologists was using a scribe. So then I tried to realize how I could integrate scribe services. I've integrated a scribe in my practice now, and I'm able to see more patients. The patients, I can spend more time actually looking at the patients, talking to the patients, and then they take care of the work of providing the note. Obviously I go through the note, but I think that streamlined services, has allowed me to see more patients, be more effective, and my patient satisfaction scores have gone up, partly because I think patients feel like they're getting more personalized care. So that's one example of how, we can learn from other specialties, take things that work with, their practices, adapt them into our practices, and become better physicians.
So that makes complete sense. So far, everything's been very positive. Can we talk about some challenges? Now, compared to something that's traditional, I see the single patient let's say prostate cancer, and then I'm referring out. What other challenges have you guys seen?
Well, I think, first is, there has to be trust issues. And, there's professional hierarchies. And, for many years, we've pigeoned patients into, radiation patients, surgical patients. You have to, establish clear roles for the providers. And I think that has to be done. There has to be, good communication. And, communication breakdowns can occur. Obviously, scheduling conflicts can happen. Um, you know, Physicians have different objectives, and what you're trying to do is align these objectives in a very straight role. It presents challenges for uh, IT services, for example. You know, the radiation oncologists use different programs than the urologists, and so there are IT challenges. Obviously, you have to have significant resources, and if you don't have proper resources, this system may not work. There are physicians that are resistant to change as well, and I think that's comes in the beginning, establishing trust, understanding, and you have to get buy-in from the group. So this is something that doesn't happen overnight. Um, it's a gradual process, and you have to have buy-in, because if you don't have buy-in from the physicians, the model really won't work. Now, can you start a multidisciplinary group with a small group of physicians? Yes. Obviously, the larger the group, we're very specialized. We're a group of 33 urologists, three radiation oncologists, two pathologists, or one radiologist. And now we're looking to add medical oncology services. So, we've been able to successfully navigate that with these specialties. But as anything, politics are all local, and how the communities that you're in may dictate whether this model will be successful. We happen to have very good oncological services here in Syracuse. It's a very private medical oncology group. We have a very large university, but we've been able to successfully navigate that environment, and look at bringing an oncologist into our practice that will just do GU oncology. And I think that the patients will benefit from that. We still want to maintain our relationships with the community providers, because there are other disease states that we will be involved in, and we want to keep good relationships with those providers as well.
Yeah, it sounds like there's just a lot more communication. And I agree with you. There are significant cultural differences between the specialties, and sometimes that's challenging, um, especially if someone is referred, let's say, for prostate cancer, and we offer them all of the options. It's a little bit different if I'm a surgeon and would recommend surgery, and then they're going to see the radiation oncologist. I think there's probably some difficult conversations that happen, but at the end of the day, truly, if the patient has the information, they'll make the best decision for themselves. And I think that's part of our job. I mean, I really applaud you for going above and beyond and actually bringing everyone together to the same table, because it's challenging sometimes, and you seem to be focused on the patient.
It really is. I mean, I think all of us put the patient first. And I think that, we want to deliver comprehensive care. We want to deliver safe care. I was fortunate enough that, this idea of a multidisciplinary clinic really kind of stemmed out of my experience when I was at Duke. Judd Mall was the chair when I was down there, and had the vision of bringing all of us together in one clinic where we'd have, medical oncology, radiation oncology, and urology. And we took turns rotating through this clinic so patients could, see all three of us in the prostate cancer clinic, for example. And, I think that model really, has now, been used by multiple academic centers around the country, and now even private practice groups, large urology practice groups, the LUGPA groups, have now started to incorporate this model because it seems to work very, very well. But there are challenges as we discussed briefly a minute ago, and obviously you have to do it in an environment that's going to be right. And obviously, every different city and practice is a little different. It may not fit one model, and you have to be able to adapt and change. And I think that's the key. And you have to trust, your partners and realize that this is really delivering better care for individuals.
That makes sense. You briefly mentioned before that there's potential for other service lines. Frequently, when we're talking about multidisciplinary or multi-D clinics, it's usually regarding prostate cancer. But of course, as urologists, we treat a myriad of problems. Are there other models that you've either seen or are thinking about creating?
Yeah, there really are. I mean, the prostate cancer model is really what I think this is initially stemmed from. But we've integrated. For example, we have two radiologists in our practice. Not only do they look at, we order PSMA scans. We have a PSMA scanner, obviously, and a CT scanner in our office. We also have an interventional radiology suite, so we can actually do prostate embolizations. We can do, fibroid embolization. So we've now looked at, bringing these specialists on, not only to incorporate urological services, but you can actually now extend that into, for example, gynecological services with fibroids, or in some orthopedic services with joints and knees and so on and so forth. Um, we've talked about, female medicine, uh, uh, bringing in a urogynecologist and having an integrated women's health center. We have a very integrated men's health center that looks at erectile dysfunction and infertility. Um, Obviously, we've got radiation services that do mostly prostate and bladder cancer. But we've also integrated, really advanced therapies like radioligand therapy for prostate cancer patients. So these are service lines that can be brought in, not only to incorporate, more comprehensive care, but also to provide different ancillary services that may not be traditionally offered in a urological practice. And obviously, medical oncology is a very large piece of this. I think, as we stated earlier, this multidisciplinary approach really probably developed from prostate cancer, but now some of the large urology group practices are becoming very non-traditional in bringing in pharmacological services. So what we've been able to do is develop an in-office dispensing program for patients, for example, with advanced prostate cancer. Many of these oral agents can now be dispensed not only by the urologist, but they can be dispensed in our office. So that just makes, again, the care more streamlined, easier for the patient, and especially when you have patients coming from afar. We have a very large catchment area in Syracuse. We extend from Syracuse all the way up to the Canadian border. We extend east to Albany, west to Rochester and Buffalo, and then down south down to Pennsylvania. So our catchment area, these patients are driving, long distances to get their care. Obviously, telehealth has had a significant role in introducing patients to our practice, but I think that you can't put a price tag on, seeing all of these providers, in one setting. It can be scheduled and coordinated that patients that come from afar can get their care, really one-stop shopping.
So, when you're expanding to these other, let's say, service lines that are not typically what we would think of as urologist led, what is the communication with the other leaders in the specialties? Because you said previously, like everyone's on an equal footing, right? It's about how can we streamline this for the patient. So, are there any other structures that are set up when that communication starts? Because let's say someone's starting this from anew. It's a brand new idea in their practice. How could those conversations flow so that the radiation oncologist would want to participate? Because not every radiation oncologist wants to be in a urology group, and maybe they're also doing something else. How could we set that up?
Well, I think, again, obviously it depends on the individuals, but I think you have to get like-minded physicians, coming together, understanding, what their mission is, what their core values are, and then try to develop a system that will encompass that. You know, uh, I treat my radiation oncologist and I view him on equal footing to any of the urologists in my group. So he's not, you know, he's a radiation oncologist, obviously, but I value his comments and I respect him for what he does and what he brings to the table because he has a skill set that I don't have. And I realize that, I know my limitations are and what his limitations are, but I also know what his strengths are. And together, I think we're better as a team rather than working individually in our silos. And so, obviously, personalities are important, bringing the right people together. But I think what you need to do is, sit down, have a hard conversation. Is this a model that people have to compromise for? You're not going to get your way every single time, but there is a value in working together. I always think that we're better as a group than we are as individuals, and when you put that model together, if you can develop a system that can be effective, beneficial both for the patient and for the physicians, and you create a culture that really is patient centered. And once that happens, then it's fun to come to work. You enjoy taking care of patients. You enjoy working with your different providers. In the private sector, I've been fortunate enough to live both the academic as well as the private sector life. And I saw this in the academic world where physicians would collaborate and work together for a mission. When I didn't think that took place actually in the private sector, but now being in the private sector, that model has been created and it works very well in the private sector just as well as the academic center. So I'll tell you, in our practice, we are like, your practice in Chicago. We have all these different specialties. We have a large research component. We aren't obviously teaching trainees, but I actually envision in the future that, we're going to need more training programs and we're going to rely on the private sector to help develop some of those trainees. They'll go through obviously the big academic centers, but there's a lot to be said about what can be done in the community. For example, I think we have probably one of the best advanced prostate cancer clinics around. And I think that residents don't get that proper training, perhaps at a big university where medical oncology does that. That's where residents, I think, could benefit. And there are certain other aspects that I think that they could benefit from this type of training in the community. So I think what we need to do is work together. I mean, the AUA has been wonderful. LUGPA has been wonderful at trying to promote, ways that we can work together to, deliver the best patient care possible.
Yeah, I think the models are changing. Our workforce is different. The next generation is different. And I really applaud you for trying to find other ways to create models that are best for the patient, and also learning experiences for us. Now, if we focus on the patient again, let's talk about the cost. Is there a benefit or a cost benefit to the patient? Are these group models covered typically by Medicare or commercial payers? Or are there other concerns that we should communicate to patients?
Yeah, I mean, there's, cost, care, and coverage, are the kind of the three big C's in healthcare. Obviously you want to provide, excellent care to the patient. That's utmost important, I think. But you need to provide it in a costly manner that's going to be beneficial for the patient, that they won't, it can be done cost effectively. And I think that our clinic and the way we've set our practice up, we're able to deliver, cost effective care. For example, I think we've seen this now with ASC models. A good example would be, doing a prostatectomy in an ASC. we're part of a private equity platform. Um, uh, our partners in Columbus, Ohio, there's a very good robotic surgeon, Ronnie Abaza, who does all his prostatectomies in the ASC. And when you look at the cost of what it is to do a robotic prostatectomy in the hospital versus what the cost is to do a robotic prostatectomy in the ASC, it's a huge difference. It's much more cost effective in the ASC. These patients actually are going home the same day. They're getting great care, and they're in and out. And, who would have thought, when I first trained, 35 years ago, 40 years ago, that you would be doing radical prostatectomies, same day surgery in an ASC. It kind of boggles the mind. But we're able to deliver cost effective care. The insurance companies see that, and obviously they're saving significant money. So it's a win-win situation for everybody. So I think you can develop this system. It can be cost effective. It can be, exceptional care. It can be synchronized care and integrated care.
So that leads me to the next question. Sounds great. We talked about some limitations. We definitely talked about the advantages. We talked about expanding it. How difficult is this really to set up? How long was the journey? How many people needed to have that initial buy-in before it gained velocity? Can you talk about just how difficult, if I'm starting from scratch?
Well, again, I think politics are local. So this is not going to be, a model that fits in every, different city or suburb. I think number one, there has to be a certain mass, you can't do this with a 1 or 2 man group, I don't think. I think you have to have a certain number of physicians because you have to, if you're going to hire a pathologist, as part of your group, you have to be able to generate enough revenue stream, to pay the pathologist, and that means you have to do enough biopsies, you have to do enough, bladder tumor resections, and so on and so forth. So I think that it's very easy if you're a large group to start to integrate these different services. The question is how big a group do you have to be? And I guess I don't really know the answer to that. I think that again, could a 5-man group hire a radiation oncologist if they have able to set up radiation services? And the answer is yes. Our group, for example, was really the growth of 2 private groups in Syracuse that came together. First started to get the urology package in place, and then said, listen, how can we deliver, bigger care, better care in a multidisciplinary approach? And as we started to add physicians, we then said, this is realistic for us to add a radiation oncologist, a pathologist, a radiologist, and it just started to grow. So I think you have to have a critical mass, but you do have to have buy-in by the group. If they're urologists that feel that they can't, treat a radiation oncologist on the same footing, then I think the system is doomed to failure. So I think that there are certain environments, larger groups are kind of the easier fruit for this to develop in. But I think as we, push these models forward, we're going to see smaller and smaller groups looking at ways that we can provide multidisciplinary care. And, we're seeing it across the board. We've integrated with colorectal surgery, for example. In our ASC, we felt that the colorectal surgeons, and the urologists do outpatient procedures. So we teamed up with colorectal surgery to form an ASC, and we've had a wonderful partnership with those surgeons, and obviously they do different procedures than a urologist, but integrating different specialties, I think, is just a natural outgrowth that will happen.
Well, thank you very much for thinking outside of the box, figuring out better, more efficient ways to use our manpower and truly benefit the patient. So I want to thank you very much, Dr. Albala, for your time and expertise with us today.
No, Jennifer, it's been a great chance to sit down and talk to you about this. This is, I think this is the future. And, it's all about patient care and providing safe and comprehensive care. And I think this is a model that at least in 2025 seems to work very well. And hopefully we'll see more and more of these types of situations developing around the country. And again, thanks for having me.
And thank you to our audience for joining us today on the AUA Leadership and Business Podcast. Until next time, continue to learn, lead, and excel.
Make AUA Leadership and Business your go-to podcast. Subscribe today by searching Leadership and Business on your favorite podcast app and enhance your leadership and business education needs. Until next time, continue to learn, lead, and excel.